Dr. Mahesh Chavhan. I am consultant endocrinologist at Apollo Hospital, Navi Mumbai. Today we are going to talk on transgender care. I have with me Professor Dr. Todd Nippoldt, Mayo Clinic Transgender Care Clinic, Rochester, Minnesota, USA. I have with us Dr. Venkatesan Chakrapani. He is a chairperson for Center for Sexuality and Health Research and Policy, Chennai. And I have Dr. Prathosh Gangadhar. He is a consultant endocrinologist at ICRA Hospital and Research Center, Calicut, Kerala. So, Professor, can you give us some idea regarding the transgender care clinic which you run in Minnesota?
Yes, I'd be glad to. I'd like to start out by just kind of reviewing the transgender population, who they are and why we're treating them. Because at least in the United States, and I'm sure in most of the world as well, transgender care has not been part of people's traditional medical education up until at least the last 5 to 10 years at the latest. So basically, in the U.S., we use the transgender term to include people primarily whose gender identity does not match the sex that they were assigned at birth. So there's a mismatch between how they feel and what their body appears to be. And gender identity is a separate, innate part of an individual, and it can be male and female, but it is non-binary as well. Some people fall in between that along a spectrum. And on the sex assigned at birth is a similar thing. There's male, female, but also there's a spectrum between those and we call those intersex conditions. And it's very important to separate gender identity from sexual orientation. Sexual orientation is the gender that an individual is physically or romantically attracted to, and those three things are totally separate, but they all work together in an individual who then expresses their selves in society. The other thing that's important to understand is that being transgender is not a disease in and of itself. It's not a disease. It's not a choice for the individual. We as medical providers get involved because many people who are transgender develop what's called gender dysphoria, this intense sense of unease regarding how they are perceived and treated in society, and their self-devaluation, etc. So the goals of treating are to relieve the dysphoria. And there's basically 4 areas that we concentrate on. One is socially transitioning, and then there is medical transitioning, and in some individuals have surgical transitioning. In addition to the social transitioning, there's also sort of a psychological self-acceptance part of it that we work with people and to help them get over their dysphoria and their sense that they're the only person who has this condition. So our treatment model encompasses all of those. So we have mental health providers who help with self-affirmation and any other issues, particular psychiatric issues that might occur as a result of that. Anxiety and depression is very high. Social transitioning includes changes in dress, makeup, comportment, those types of things. And then medical management is what we do as endocrinologists, but in fact in the U.S. the vast majority of people who manage transgender hormonals are primary care physicians or primary care, what we call mid-level providers, nurse practitioners often. And the goals of medical therapy are to relieve the dysphoria, and we do that by in individuals who are transitioning from a male body to a female body. We use androgen blocking drugs, usually spironolactone, in high doses. It acts as an androgen blocker, as you know, and helps with feminization. And then we usually use estradiol. And estradiol does two things. It suppresses endogenous testosterone production, and then, of course, allows for the feminization to occur. We always assess some baseline medical issues, particularly histories of blood clot, cardiovascular disease, hyperlipidemia, all these things that can be influenced by the hormonal therapy. If they're off beforehand, we correct them, and then we monitor, because sometimes, for instance, oral estrogen may result in hypertriglyceridemia, and we need to monitor about that. The next part of the medical management for trans women is progesterone, and that's a controversial thing. It's felt that in some individuals that helps with breast development, and I've also noticed that many people actually have a much better sense of well-being when they take progesterone. From the standpoint of masculinizing hormone therapy for trans men, so transitioning from a female body to a male body, the basic medication we use is testosterone. And usually we use that in the injectable form. It's easier to titrate. We like to start out with lower doses and gradually increase them up. And our goal is to get the blood levels of testosterone in trans men and estradiol in trans women in the cisgender reference range. And cisgender are people whose gender identity matches their sex assigned at birth. So, and then, after that, some individuals proceed to have surgical procedures, anywhere from facial feminization procedures to breast augmentation in trans women, breast reduction in trans men, and genital surgeries as well, vaginoplasty for trans women, and what's called metoidoplasty or phalloplasty to develop a phallus in trans men. I was surprised when I was getting into this that, at least in the U.S., only around 10 or to 15% of trans women have had the genital surgery, although about 45-50% would want it at some point in time. And only about 1 to 2% of trans men have had the phalloplasty procedures.
Thank you, sir. You have summarized it very nicely. And I would like to ask Dr. Venkatesan about the current legal issues which we are facing in providing hormonal therapy in gender affirmative surgeries and further management.
Okay. So actually many providers, including endocrinologists, they are concerned about getting into medical legal cases. So that is the main fear which prevent many people to provide care for transgender people. So it is important that we have to understand what is the legal context behind the transgender healthcare in India. Recently, actually in August this year August, a bill called Transgender Protection of Rights Bill was introduced in the Lok Sabha and subsequently passed. The bill is yet to be approved by the Rajya Sabha, but eventually it may happen. So the bill clearly talks about the need to provide gender affirmative treatments for trans people. It specifically mentions about hormonal therapy and specifically articulates the gender affirmative surgeries. Both need to be provided within the government hospital. It talks about need to provide in the government hospitals, need for having a medical insurance, a comprehensive medical insurance for trans people, So in that way, it is quite progressive. It also mentions about an international guideline which is called World Professional Association of Transgender Health, WPATH guidelines, specifically
WPATH.
mention that even it's an international guideline, but it specifies that the providers here, they are supposed to follow that kind of international guidelines, established guidelines. So I think people need not worry, for example, whether I can provide a hormone if the person is already diagnosed as having, say, gender incongruence or gender dysphoria. Then people need not worry about like prescribing hormones for those patients. So there are some particular criteria which is mentioned in the WPATH guidelines, as I think Dr. Todd also pointed out, like about the medical management. So one another aspect, legal aspect, which I want to highlight is if there is discrimination towards trans people, whether by a doctor or in an establishment, whether it is government or private, doesn't matter. There is actually it is considered as crime. Actually, it's so there is a specific clauses. There are specific clauses which talks about not discriminating people who are transgender, especially in the healthcare settings. So these issues, I think, the physicians need to keep in mind, and they have to equip themselves to understand better about the trans people, and also how to not only sensitively provide care but also provide competent like care. They have to become more competent, equip themselves with a better knowledge, maybe shadow people who are already like worked with the transgender people. So these could be some of the, I think, options like yeah.
So can you elaborate on the ethical issues involved in
Yes,
yes, gender affirmative surgeries?
Yes, yeah. For example, because I'm also a public health researcher on sexual and gender minority issues, in one of my studies, a provider actually told that I don't want to provide hormones or surgery because I don't want to harm a normal body. So the providers, this is basically because of, I would say, like maybe ignorance on the part of the provider that this is a condition, gender incongruence, which need to be treated with hormones and surgery. Not all people require hormones and surgery. For those people who require, we should be in a position to provide. So this resistance among certain providers is actually an ethical issue, because if you don't want to provide, otherwise you are capable of providing that, or if you are actually attempting to what they call conversion therapy. Some providers, I heard that they actually counsel people, especially adolescents, that you should not be behaving like this. If you are born as a male, you should behave like a male. So these are very clear, like professional ethical issues. So this is in relation to like providing treatment, like initiation of treatment. But there are also ethical concerns in once you start the treatment. Before you start the treatment, even actually we need to counsel the trans people about what other options available for them in relation to fertility preservation. The Endocrine Society USA actually recommends full counseling on fertility preservation for all trans people, and then they need to take up, because people should not be later regret that I should have done it before. So, and one key ethical issue is many people struggle with is in the provision of care for legal minors. If the person is less than 18 years, people are worried whether I can provide hormonal therapy, whether I can provide surgery, even if it is medically indicated by the guidelines. Even if the criteria of the guidelines are actually met, people still have concerns and reservations. So I think if they can able to follow the guidelines, actually the current bill from the government clearly states that you can provide if it is medically indicated. So they can actually cite this is medically indicated, and then they can follow whatever procedures which are mentioned in the guidelines, and there should not be any legal issues or maybe even ethical issues. They can consult with other seniors also if they have any queries.
Thank you, Dr. Venkatesan. Coming to Dr. Prathosh, can you give us an Indian perspective on about the gender,
Thank you, Dr.
transgender
Chavhan.
care?
as both of our experts discussed regarding the management part of gender dysphoria as well as the ethical and medico-legal aspects. So I have to speak regarding the Indian perspective of transgender care. India estimated to have around 2 million transgender, although according to the census it's nearly 0.48 million is documented to have the transgender issue. And the landmark Nalsa judgment by Supreme Court, Honorary Supreme Court of India in April 2015 identified transgender as a separate third gender identity, and that gave them specific privilege as a minority. And Indian government is actually supporting transgender care in a big way now. But now we are, as a treating endocrinologists, we know that gender dysphoria, as once diagnosed and confirmed by the mental health professional, and it's not properly treated or it's persisting, then it should be treated as eminently told by Prof, by either hormone therapy or by surgery. And currently in Indian scenario, we need to speak regarding the Indian perspective. We did a survey prior to this conference regarding Indian endocrinologists' practice pattern regarding transgender care. What we found was that nearly 40% of the Indian endocrinologists are not practicing into the transgender care, and there are a lot of concerns with the Indian endocrinologists. Many of the concerns are, as rightly pointed out, the medico-legal confusions, and other thing is the lack of training during transgender training in the DM or residency period during their endocrine training. And, other part is the lack of multidisciplinary care to integrate the care. So, and these are the major concerns raised by Indian endocrinologists during this survey. And another point we noted was that lack of in-depth knowledge of multidisciplinary guidelines. Especially, we know that there is Endocrine Society guideline 2017 that is specifically going towards the endocrine management part, but the multidisciplinary guideline, there is one guideline, GSC guideline in India that is published in 2017 by multidisciplinary team, but still many of the endocrinologists are not actually following that guideline. So that is a concern in Indian practice we are facing. And finally, in my perspective, I am a novice to in transgender care because I am not seeing a lot of transgender patients. But recently, I am proud to say that our state of Kerala actually started transgender policy by the Department of Social Justice in 2015 itself, after the Supreme Court verdict. And now our state actually is set and actually selected by the transgender people in the recently concluded IPATH conference in Delhi as the most preferred state to live for transgender population here in India. And Dr. Suja, I had to mention her name, she is taking care of the transgender people with an integrated clinic, and now actually Kerala government is supporting her, although in the private sector, supporting her clinic setup because she is giving very good integrated care to the transgender population. So that is a much needed changes that we are seeing in transgender care, although a lot of new things has to be added to that particular spectrum.
So, Professor Todd, coming to this non-binary assignment of, so do people want to refer them as transgender, or they just want to be referred as a non-binary type of gender?
Yeah, so individuals that don't identify, as the binary male or female, but along the interval between there, there's lots of terms that are used for that, and they evolve as time goes on. Currently, the primary terms that are used are gender non-binary, gender non-conforming, and even a gender queer is an acceptable form to describe that, and people identify that way. And it's important to accept that, and once again, I just need to re-emphasize that it's really not a choice, and even in individuals there's some individuals who are define themselves as gender fluid, where they may alternate or move more towards one end of the spectrum and the other, and that's just the way the people are, and we try to help them as best we can. Once again, with the goal to relieve any discomfort and dysphoria that they're experiencing.
So is this treatment considered under insurance, like he has mentioned? India is making a law regarding that.
Yes. So that's been a big thing, and for up until 2015, the insurance coverage was very poor for transgender people in the U.S. In 2015, Medicare, which is the U.S. government's medical program for older people, and also Medicaid is part of that for poor people, they had specifically had exclusions for transgender care. They removed those exclusions in 2015, and with that, the private insurance companies started to also offer coverage. So right now, it's actually it's still an issue, but it's a lot better issue. If you happen to have insurance through a large company, you have real good care. And also the government managed care for the poor people is also quite good.
Is all these hormonal treatments are costlier. So what do you think, Dr. Venkatesan, about how to cost affordability regarding this gender affirmative surgeries and the treatment further on? How is the government going to help, or the insurance companies, or what are the issues which are going to?
I think
we can talk.
Our state, actually, Kerala government has a health policy that actually supports transgender gender affirmation surgery. They give 2 lakhs rupees for transgender patient, as well as post-op they will get an allowance of 3,000 rupees per month till
to continuous of the therapy.
So this is through the government support by Social Justice Department. So that's a good thing, and now they are integrating the private clinic into the government setup, because she is doing a great care. Because a lot of transgender people are under her care right now. So that's a good thing to have.
Yeah, and one thing too that I think goes, when you get down to it, the hormonal management is really not that expensive if you don't have to use these GnRH analogs. Those are the only expensive part, and managing the dysphoria actually has a very positive outcome. It gets people back to work, they become more productive, and you get benefits that way. And it's interesting, in San Francisco, the county of San Francisco made a policy that they were going to cover all transgender care, including surgeries. And it turned out that was a very tiny part of their budget, and it only had positive impacts down the road.
Okay. So actually, regarding the cost of for example, if it is a feminizing hormonal therapy, so the cost will be anywhere around, like, say, 250 rupees per month to 1,000 rupees per month, depending upon the regimens. If it is a masculinizing hormones, it may be a little higher. Of course, GnRH analogs much more, like it's very costly, because that's primarily used in, especially in children and adults, and so that's a issue. Most middle socioeconomic status people, maybe they can able to afford, but still, because this is going to be more like a lifelong for some, so then the cost accumulates. So that is one. And another is, it's not just the cost of the drugs, but there's also lab test, visit to the clinic. So those costs also we need to take into consideration.
And if we consider the surgical cost, then the cost
climbs. Yeah, obviously, because surgery, only very few government hospitals they provide surgery. Of course, he mentioned about the reimbursement policy by the Kerala government. In Chennai government hospital, in some government hospitals, they are providing it for free, even though the surgery, even though the patients need to buy silicone implants themselves, like that is additional, like say anywhere from 20,000 rupees to 30,000. So there were always like additional cost. But I was surprised to know there are some private health insurance companies which actually can able to cover the hormonal therapy cost.
Wow.
So I don't want to name them, but they are available
They are
actually. So yeah.
Okay.
So regarding sir, in your clinic, how many patients do you see there per month?
Yes. Well, right now we've been an official clinic for it'll be 5 years in January. So we're new at the game here. We started out slowly and gradually increased. Right now we have 2, 4, 6, 8. We have 8 new patients a week.
Wow.
The majority of those are filled. Sometimes they're not. And then we have the continuity practice as well in addition to that. Being a referral center, as Mayo Clinic is, we see a lot of patients that are getting their hormonal care and behavioral health care locally, but come to our clinic for the surgical procedures. And that is probably, I would say right now, perhaps a third of our entire number of patients that we see.
So Dr. Prathosh, how many patients to your clinic there in
Actually, I already
Your-
told.
yeah,
I'm
yeah.
No ways, but the
On an
person
average.
I am speaking, she is taking care of around 270 patients over last 2 years,
Wow.
or period of 2 years. That's a
That's yeah,
huge number.
It's
it is.
it's gaining popularity as it gains popularity and as more medical centers become available.
Yeah.
Uh,
And that's been the issue. Medical care has not been available for so long, and so one could say there's a backlog. You know, of people are finally get an opportunity to get the care they need. They will come.
And regarding the few of the surgeries which you spoke, like the facial surgeries or the breast augmentation or breast reduction surgeries, so are they covered in your insurance or they are just
That's those two issues. The ones that are covered are without the vast majority of things that are covered by insurance policies are the genital surgeries, breast reduction for trans men, but the issue comes for breast augmentation for trans women and facial feminization for trans women, simply because insurance companies, their rationale for not covering those for the transgender population is they are considered cosmetic for the cisgender population, and that would be a mismatch. Now, you could certainly argue that the cisgender population wanting a cosmetic procedure is really not the same as someone with gender dysphoria who needs this to have a productive life. But those are the two that are have the most difficulty trying to get coverage for our patients.
Dr. Venkatesan, can you elaborate on the law which has been passed in Rajya Sabha? Can you just say a few more words about that?
Yeah, so I mentioned about the bill. It's currently, even now it's a bill stage, not
as a law.
So it is called Transgender Protection of Rights Bill 2019. So as I told, it just passed like in the Lok Sabha, the lower house of the Indian Parliament. It will be eventually submitted to the Rajya Sabha. Actually, even before that, they had a standing committee which looked at this bill and actually provided some suggestions, including the need to add or strengthen the insurance component. It was primarily from the standing committee, parliamentary standing committee, which was specifically constituted to look at this particular issue. Even though there are aspects in the bill which are seen as quite progressive, there are also criticisms in relation to the in relation to certain clauses. For example, one main criticism is even this happens in providers also. Healthcare providers also sometimes they get confused between intersex people and transgender people. So if you look at the bill, there is a separate definition of intersex people, which is good. But when you look at the definition of the transgender pill, they have also added people with intersex variation. So that is a problem. But because as you know, as clinicians know, the management of transgender people are different from management of intersex people, even though technically some percentage of intersex people can be transgender. But still, the clinical management are quite different. So this bill, which was supposed to be primarily for transgender, and then the name itself says transgender, and then it actually mentions a term which is not approved within the international medical literature or by the WHO. So then that's a problem. So that's one criticism. Another main criticism is because Dr. Prathosh also mentioned about the Supreme Court judgment in 2014 actually. So it mentioned that trans people, they have the right to choose their gender. So I can actually choose myself, I can identify myself as a man, women or transgender. It is not like transgender people need to be identifying only as transgender or third gender or third sex. That is a confusion. Actually, I have that option. So that is that. And the Supreme Court clearly mentioned about in the 2014 judgment self-affirmation of the gender identity, and there's a very specific clause which mentions that there is no need for any medical or surgical procedure, which means people, even if they are not on hormones, not undergone surgery, they have the right to identify in the gender they perceive or they would like other people to recognize as. That actually is diluted in this particular bill, because there's a confusing aspect which mentions that if a transgender person wants to be identified as a transgender, then the transgender person needs to submit an application to the district magistrate, who is usually the district collector, who then shall provide certificate of identity to the transgender person. So this is apparently, I assume it is primarily for social welfare schemes, but the problem is some providers are concerned. So before I start the hormonal therapy, whether should I ask the person to get a certificate from the district collector, which is not at all which is not connected actually. So that is primarily supposed to be for the access to the social welfare schemes. For example, in Tamil Nadu there is a transgender social welfare board. For that, some people they want identity card, and then they apply to a panel and then get the identity card. So there are some aspects legal aspects which is actually not that much progressive. One surprisingly progressive thing was, if I got the identity after, because there's one clause which says after operation, again this is a problem, you need to get the certificate from the doctor and then apply to change the gender. Okay, even if we consider that as okay. But some people, they think that this again violates the principle of the Supreme Court judgment. The progressive thing I was talking about, this is not the progressive thing. The progressive thing was, if I got the gender changed, then I can go back and change my first name in the birth certificate. So that is actually a very progressive judgment, which people actually did not even imagine here. So they can make all the changes in the educational certificates, so that there is no problem when they go for employment.
Right.
But can a person who has undergone a surgery and is irreversible, can he go back in this law, the bill? Can he go back and okay, I'm not satisfied with these results?
Okay, the bill is silent about that, but I think Dr. Todd can also answer that there are few, I think, regrets, the true regrets, following a really properly assessed gender incongruence condition. Maybe I think you may be in a better position to answer that.
I agree. The regrets for proceeding with either hormonal therapy or surgical therapy is very, very small. And usually when it's when they have regrets, it's not because they felt that their identity wasn't true. It was, pain or poor outcomes and poor cosmetic outcomes from the surgeries.
So thank you, Professor Todd. Thank you, Dr. Prathosh. Thank you, Dr. Venkatesan. Such an elaborate discussion on transgender care, and I think the audience would be much enlightened with the care which is being provided in the Western world and the Indian scenario, the things to come. Thank you.
Thank you very much.